Well, hello, everyone. I'm Dr. Renee Bullock-Palmer, one of the section editors for Circulation Imaging Journal. Welcome to our inaugural Circulation Imaging case webinar series titled The Usefulness of Advanced Non-Invasive Imaging to Guide Structural Heart Disease Intervention, Learning from Real Cases. Today, I'm joined by the other section editors, Dr. Otavio Coelho-Filho and Dr. Ahmad Masri, who have also helped put this webinar together. Today's webinar will include presentation and expert panel discussions of 3 case manuscripts that have been or will be published in the Circulation Imaging Journal. And our expert panelists includes our editor-in-chief, Dr. Rob Gropler, as well as our senior guest editor, Dr. Linda Gillam, the associate editor, Dr. Nozomi Watanabe, and editorial board member, Dr. Roberto. And I'd like to also invite the attendees to post their questions in the Q&A box, and we'll try to address those during the panel discussion. And before case presentation and discussions, I'd like to turn things over to Dr. Gropler for some opening remarks. Dr. Gropler.
Renee, thank you. And I just want to welcome everyone to this inaugural imaging case conference. We're absolutely thrilled this is happening. This is something we've talked about since I started, and I'm so happy and thrilled that Renee, Ahmad, and Otavio made this happen with obviously the strong support of the AHA. Let's face it, we're imagers. We learn by looking at images, talking about them, and discussing them. And we have 3 incredibly high quality imaging cases. I want to compliment the authors on those. They were superb, and we don't accept many of them. I mean, they're in single digits that we accept, so congratulations on that. I also want to thank our panelists that are joining us. Linda and Roberto and Nozomi. I think it'll be a wonderful discussion. I unfortunately cannot stay. I have another meeting I have to go to, but I look forward to seeing the recording and many more of these to come in the future. So again, congratulations to everyone. This is, I think, just a phenomenal event. So thank you again. Renee, back to you.
Thank you, Dr. Gropler. So we'll start off with our first case, which is titled Anterior Mitral Leaflet Dissection and Pseudoaneurysm late after transcatheter aortic valve replacement, looking beyond the obvious. And the case presentation will be done by Dr. David Del Val. So over to you, David.
So good evening from Spain, and thank you very much to the organizer for allowing me to participate in this interesting webinar. I'm David Del Val, interventional cardiologist at La Princesa Hospital in Madrid, and I would like to present you this case of anterior mitral leaflet dissection and pseudoaneurysm late after TAVR. So it's about an 89-year-old woman with a clinical history of hypertension, dyslipidemia, long-standing persistent atrial fibrillation. She had also a permanent pacemaker due to a high-grade AV block. And the patient had a symptomatic severe aortic stenosis, and she was deemed candidate for transcatheter aortic valve replacement by our local heart team. So the procedure was performed through the right transfemoral approach using a self-expanding valve. Here you can see the images of the procedure. There was a significant paravalvular aortic leak after the initial deployment. And therefore, we decided to post-dilate the prosthesis with a high-pressure balloon. And here you can see the final result. There was a good final result. We just admired residual paravalvular aortic leak regurgitation. There were no complications after the procedure, and the patient was discharged 3 days later with a transthoracic echocardiography without any relevant finding. But 4 months after the procedure, the patient was admitted with acute heart failure and fever with unknown origin. So we performed a TTE at admission that showed an extensive anterior mitral leaflet dissection with a large pseudoaneurysm of A2 and a mild mitral regurgitation. And the TEE provide more details and show a large pulsatile tunnel-shaped cavity that filled during systole, posterolateral to the aortic annulus in the mitral aortic fibrosis, extending to the anterior mitral valve leaflet pseudoaneurysm. Importantly, there were no vegetation and there were no dysfunction of the TAVI prosthesis. So based on these echo findings and the high initial suspicion of infective endocarditis, we obtained blood culture and we start a broad spectrum antibiotic therapy. And the next day, the patient underwent an 18 FDG PET CT, and surprisingly, we observed a completely normal uptake pattern in both the TAVI prosthesis and the mitral valve. In addition to this normal PET CT, the blood cultures were negative, and finally, we identified an urinary tract infection as the cause of fever. So the diagnosis of acute infective endocarditis was finally rejected. The patient refused surgery, and despite an initial clinical improvement with medical therapy, the patient had a rapid clinical deterioration with a refractory heart failure and severe mitral regurgitation, and she died 7 days after admission. So in order to better clarify the mechanism of this mitral valve alteration, we request an autopsy. And here I show you the anatomopathological images. In the first images, you can see the anterior mitral leaflet pseudoaneurysm. In the second one, we can identify a wall disruption in the LVOT in close relationship with the lower edge of the TAVI prosthesis. And the microscopic images, we can see a permeable tunnel shape in connection with the low LVOT and the pseudoaneurysm in the anterior mitral leaflet. And this finding had a good correlation with the echocardiographic results that showed a wall rupture in the LVOT in the lower edge of the TAVI prosthesis, and a tunnel-shaped structure connecting the LVOT and the anterior mitral leaflet, leading to a pseudoaneurysm of A2. And what is the explanation of these findings? Well, it should be noted that the patient had a severe LVOT calcification, as you can see in the procedural CT and also in the fluoroscopy. So our theory is that during the TAVI prosthesis, during the TAVI procedure, and probably after the post-dilatation, there were a contained annulus rupture at the distal edge of the prosthesis that slowly and progressive create a dissection of the mitral aortic junction, creating a pseudoaneurysm of the anterior mitral leaflet. So these are the key learning points of this case. The aortic annulus rupture after TAVI is an unusual but life-threatening complication. Pre-procedural advanced imaging modality may be essential to identify anatomic issues that could potentially increase the risk. Post-dilatation of TAVI prosthesis to treat residual periprosthesis aortic regurgitation should be performed cautiously, particularly in those patients with severe LVOT calcification. And a high degree of clinical suspicion is critical because delayed diagnosis and treatment may be associated with a poor prognosis. Thank you very much.
Great, thank you so much, Dr. Del Val. So we'll open it up to our panelists, and I'll encourage the attendees to please enter your questions in the Q&A box. So Dr. Gillam, what are your thoughts on the case? Do you have any suggestions or questions?
So first of all, just compliments. I mean, it's really, as you said, a very unusual complication, and one that was really documented beautifully, both in terms of positive findings and negative findings with the FDG PET, to help you exclude infective endocarditis. So I do have a question, and sometimes in these, and it looks like yours did not dissect into the pericardial space, rather it took this unusual pattern. But was there any involvement of the pericardial space, and was at autopsy, you had an autopsy follow-up echoes, or was it really limited to this pathway along dissecting through the anterior leaflet?
Yes, that's what's only the dissection of the anterior mitral leaflet, and there were not other finding in the images. So there was not a involvement of any other structure.
And the one other more of a comment than a question. I mean, sometimes, particularly in maybe the old days when we routinely did transesophageal echo, we do it much less frequently now. We could see these spicules of calcium, and there was definitely calcium there, and you could just see, especially with balloon dilatation, the whether it be just the balloon alone or balloon dilatation of a balloon expandable valve, you would just see like this sharp spike of calcium kind of tensing, and you'd obviously keep your fingers crossed that there wasn't rupture. But when the at any time during fluoroscopy, could you sort of see the presumably the culprit calcium just kind of bouncing and in a way that you kind of held your breath and said, hopefully nothing bad will happen?
Yeah, I completely agree with that. Sometimes we underestimate the presence of calcium, particularly in the lower age of the prosthesis, and sometimes we cross the fingers with nothing happened. This is a very rare complication, but this case illustrates an unusual scenario that it should be taken into account for other patients, particularly in those patients with severe annulus or left ventricular out of plaque calcification.
Great. So thanks, Dr. Gillam. So Dr. Lang, any thoughts on this case?
Thank you. So thank you for the presentation. Very interesting and very unique and rare case. So maybe a little bit more of a provocative question here. Now in retrospect, and you see this, what appears at least to be sort of a narrow left ventricular outflow tract that is extremely calcified. Can you maybe explain us why did you use a balloon expandable versus a self-expandable TAVR? What is your decision as to making that? And then retrospectively, is this a patient in which you would have considered doing a SAVR instead of a TAVR due to the extensive calcification? Was that something that was come into consideration or not?
The problem here is that the patient was 89 years old. She was a frail patient at a high risk of surgery. So the patient was considered a good candidate for TAVR. And in our center, we had more experience with a self-expanding valve. And also there are some series that they have provide more rate of annulus rupture with balloon expandable valves. So in this case, and based on our experience, we consider that the self-expanding valves were more safe for the patient. But unfortunately, the result was not optimal. That's true. But we consider that taking into account the calcification of the LVOT, so the safest prosthesis was the self-expanding valve.
And okay, that is a good sort of explanation to say that. But in your experience, meaning you use these self-expandable valves in what percentage of patients over the years or lately have you seen still important perivalvular leaks that merit another balloon expansion? And how successful is that to reduce a perivalvular leak?
So I think around 50% 15–20% of patients with severe calcification of the LVOT is common to need a post-dilatation for an optimal result. That's true that in patients with very extensive calcification, sometimes we don't want to achieve a perfect result with a zero paravalvular regurgitation. So in these cases, for example, just after the deployment, the first deployment, we had a significant paravalvular leak, and after the dilatation, the post-dilatation that was not very aggressive, we achieve a good result with just a mild paravalvular aortic regurgitation. So we consider, given the risk of complication, we consider that was a good result for a patient of 89 years old.
Thank you.
So Dr. Watanabe, do you have any questions or points, learning points?
Yeah. Hello, David. Congratulations. This is really unique and horrible complication case, and the images were superb. Thank you very much for sharing this. And I wanted to ask you, it is related to Linda's question maybe, but could you find any hint or early sign of this serious complication when you look back, when you review the intra or post operative TTE or TEE, so on? If you could find any sign of early sign of this complication, could you tell us about that? Or no sign?
We perform maybe not. So we perform the post-procedural echo 24 hours, and we have reviewed several times the images. We have not identified nothing that can suspect a complication like an annulus rupture or something like that. So I think it's not easy. It's not easy. And the patient was completely asymptomatic 4 months. So she started with the worsening heart failure 4 months after the procedure. So I think it's something that it was created very slowly, very progressive during the weeks after the procedure. I think it's very tiny annulus rupture or contained annulus rupture is not easy to identify with common echocardiography images after the procedure.
Yeah. So I assume probably it was difficult to evaluate the annular, the leaflet site due to the stent artifact, maybe, especially the site of aneurysm. Yeah, I assume so.
This is another handicap. That's true. That's true. I
so
agree.
The aneurysm was not perforated, yeah?
No. This was not perforated at the beginning. That's true that when the patient had a clinical deterioration some days after admission, that's true that he had a severe mitral regurgitation, and there were signs of perforation, but at the beginning there was not perforated.
Okay, thank you. Great case.
So David, we have a few questions from the audience. So one question from Dr. Chan, the TE had showed no MR, but she apparently had MR clinically. Any explanation for this?
Sorry, the TE?
Right, so Dr. Chan had mentioned that the TE had showed no MR, but she apparently had MR clinically. Any explanation for this?
So at the beginning, the patient had a mild mitral regurgitation at presentation. That's true that some days later, the clinical status and the MR was getting bad, and finally the patient had a severe mitral regurgitation. But at the early beginning, there was only mild mitral regurgitation.
Right. And sometimes with acute MR, it can be very difficult if it's acute MR to really pick that up on Doppler sometimes. So,
yeah.
Right. There's another question from Dr. Constantin, what was the oversizing percentage of the prosthetic valve that was chosen?
So I don't remember exactly the percentage, but is what not a limit decision in the TAVR size. So there was a patient just in the middle. So I think it was not a problem of the oversight of the prosthesis.
Right. And for a question for more section editor, Dr. Coelho, how would you modify, so in a future case intervention such as this, how would you modify your approach to the intervention? I think Dr. Lang had mentioned probably SAVR may have been a better option. Are there any other changes you'd make to your intervention in such a patient?
So I think in this patient with an extensive calcification of the LVOT, the decision of the post-dilatation, it should be well, it's something to debate, because sometimes it's better to accept as a mild to moderate aortic regurgitation, paravalvular aortic regurgitation, rather than a severe complication or serious complication like a annulus rupture. But that's true that it's very rare. It's a very rare complication. So most of the cases, even with anesthetic calcification, there are no complications. So I think, but it's something to take into account when we decide to post-dilate a TAVI prosthesis.
And then final question, and I'll open it up to any of the panelists. Besides the heavy calcification of the LVOT, are there any other markers that our audience should look out for when we're choosing these cases for TAVR? Are there any other features that could suggest an increased risk for annular rupture?
For the annular rupture, I think, in my personal opinion, I think that the calcification is one of the most important marker. So I think is one of the most important predictor is the calcification. So I think is that I don't know exactly if there is other options that could be, but in this case the predictor and the cause of the final annular ruptures was the calcification.
Great. Thank you very much, Dr. Del Val. So Dr. Masri, I'll turn things over to you.
Thank you, Dr. Bullock-Palmer. My name is Ahmad Masri, and I'm one also of the section editors. It's my pleasure next to introduce Dr. Alessandro Beneduce, who is an interventional cardiologist at San Rafael Hospital in Milan, and who is currently doing a fellowship in Clinique Pasteur in Toulouse in France. The next case presentation is in regard to a transcatheter mitral paravalvular leak closure using arteriovenous rail across an aortic bileaflet mechanical prosthesis, a multimodality imaging approach. Alessandro, I turn it over to you.
Hi, everyone. Thank you, Dr. Masri, for this kind introduction. So I'm really glad to be here with you for this fantastic initiative, and I'm glad to share with you this case, which I think really shows you how modern multi-procedure and multi-modality imaging can be really a game changer for complex structural heart interventions. These are my conflicts of interest. So in 2021, we received a 71-year-old gentleman with several comorbidities and a history of multiple reduced surgical valve procedures who had a mechanical mitral and aortic valve replacement and a tricuspid annuloplasty. This patient presented for heart failure and severe hemolysis requiring multiple transfusions. At the time of the admission, transthoracic echocardiography revealed a mitral paravalvular leak, which was causing only mild MR, but with a severe eccentric jet, which was deemed to be likely the causing hemolysis. The prosthesis, the mechanical prosthesis, were well functioning. However, the tricuspid annuloplasty failed, causing severe TR, and the patient ended with a preserved left and right ventricular function. Looking at his clinical profile, he was in class 2, he had a good life expectancy, but it was deemed at high risk for surgery, and therefore the indication was to percutaneous PVL closure after heart team discussion. So we started our planning with three-dimensional transesophageal echocardiography assessment, which showed, as you can clearly see in these images, a single paravalvular leak in a posterior and lateral location, a very tricky location, as you will see later on for transcatheter transseptal closure. The defect was a single defect with very small diameters and a crescentic shape, which was causing an eccentric jet, as you can see on the right panels in these three-dimensional color Doppler reconstructions. And based on these informations, we then decided to proceed with a single device closure using an Platzer vascular plug tree. And we decided to do this procedure from a transseptal approach using fusion imaging for guidance. And at this time point, it is important to notice that as per our practice, we also performed a computed tomography, which was used mainly for three purposes. First of all, to confirm these findings, then to derive the optimal fluoroscopic projection, and finally also to plan the transseptal puncture. I'm not showing you the CT right now, we will see it later on. Because then after the TOE, we went to the cath lab, we performed our transseptal puncture, we wired the PVL with a polymer-coated wire. We used supportive guide wires to try to deliver our equipment, but as you can see, we had a problem. We did not have enough support to cross the PVL, and this was probably due to its narrow and tortuous path. So at this time point, we decided to stop due to the high radiation dose it was already delivered to the patient, and we had to rethink about our strategy. We had mainly two options in this scenario. So first of all, to switch our procedure to convert from a transseptal to a transapical approach, which was, however, deemed very invasive for the patient. And the second option was to use an arteriovenous railway, which is something that is considered usually as a last resort option in these patients who present a mechanical aortic valve due to the high predicted risk of instability and hemodynamic decompensation due to an interaction with leaflet's function. And so therefore, we had to step back and to rethink about our strategy, and we decided to do so by looking at our CT scan. As you can see from this 4D CT assessment, we really focused at the beginning on the mechanics of the aortic prosthesis. As you can see, the leaflets, the mechanical leaflets of this prosthesis move around the hinge point. It is the green dot that you can see here, which is therefore creating a triple opening in this valve. This valve has two big lateral openings and a central narrow opening. And if you think about the mechanics of the lever, you realize that actually it is very easy to move these leaflets, to create a movement in these leaflets with your guide wire. If your guide wire passes through one of these wide lateral opening due to a very long lever arm, while it is anticipated that interaction with the leaflet could be reduced if you are able to pass through the central opening. Therefore, we decided to target the central opening, to pass the guide wire through the central opening to realize the AV railway. But we also had a look at the three-dimensional relationship between the PVL location and the orientation of the aortic prosthesis, especially the orientation of the leaflets of the aortic prosthesis. We realized that we were in a favorable situation with the leaflets oriented parallel to the anticipated trajectory of the guide wire, which was also not very angulated, and therefore we anticipated a very good interaction targeting the central opening of the prosthesis. And we went back to the cath lab We performed our procedure using transesophageal echocardiography monitoring. We performed our transeptal puncture targeting an anterior and low position in order to use our steerable catheter and an additional catheter to get an additional curve to be very really in the axis of the PVL and to facilitate crossing. Therefore, we performed our procedure. We realized the AV railway. We advanced an hydrophilic guide wire. We targeted the central opening of the aortic prosthesis, and we snared this guide wire in the aorta, and we externalized it through the femoral artery, realizing therefore our AV rail. We did so under careful hemodynamic monitoring and the wire tension balancing during each maneuver in order to be nice and safe. And we performed our procedure using a fusion imaging monitoring, which really enabled us to easily cross the PVL, but also to have a constant look at the function of the aortic prosthesis and the mitral prosthesis, and to assess our final result in real time. We successfully delivered our single Amplatzer vascular plug through the PVL, and we closed the defect effectively. The patient was stable throughout all the procedure, and our final result showed a very good result with only a trivial residual jet. The patient was discharged safely, asymptomatic, and a 30-day follow-up revealed a complete resolution of hemolysis with stable hemoglobin levels. So this is a slide that actually shows you the multiple imaging modalities that we used in this case. Actually, the three-dimensional echocardiography was used for procedural planning to identify the PVL number, size, and shape, but also to quantify MR and to exclude the contraindication to this procedure, namely the presence of infective endocarditis and an excessive movement of the prosthesis. Then we used the 4D CT approach for procedural planning, namely planning the transeptal puncture, the identifying fluoroscopic angles that could help to better cross the PVL, and also to study the mechanics and the orientation of the aortic valve, and anticipate the guide wire trajectory. And finally, the fusion imaging was very useful to facilitate PVL crossing, to understand real-time the functionality of this mechanical prosthesis, and to assess our final result. Therefore, mitral PVL closure is a technical demanding procedure. It requires really a multimodality imaging planning and guidance. And we know that arteriovenous railway can be a solution to increase support. Actually, this technique is generally considered contraindicated in patients with aortic prosthesis. However, using a CT imaging approach to understand the feasibility of AV railway may extend the indication of this procedure. Thank you very much.
Thank you, Dr. Beneduce. This is a fantastic case. Congratulations. I am not an interventional cardiologist, but I do think that this is a fantastic case, as well as the use of multimodality imaging. You highlighted it probably better than most other cases where there is a lot of intervention, approaches happening plus imaging being utilized. So thank you for that. I want to open up for our panelists to see if they have any comments or questions.
Hi, this is Nozomi Watanabe. Congratulations on your great case showing the role of multimodality images in this kind of complex case. I wanted to ask you that about the full fusion imaging. So you mentioned that the fusion imaging was helpful in this during the procedure. And could you tell us a bit more in detail how did you use the flow fusion imaging in this case? I think it is of interest. It should be of interest how practically we can use those fusion imaging.
Yeah, sure. Thank you very much, Dr. Watanabe. It's a very, very good question. Actually, what we can do in the cath lab is using together the fluoroscopy images with other imaging modalities. We can use CT images, and we can also use echocardiography, namely transesophageal echocardiography, and as in this case. We commonly do this for diffusion imaging, use diffusion imaging for complex procedures like this one, especially when we really want to shorten procedural time and really to understand better some structures that probably are not easily visible in fluoroscopy alone, especially with, let's say, in other cases with biological prosthesis, or in this case, when we want to really to monitor the functioning of mechanical prosthesis in general, and also to understand better the interaction of our devices with this prosthesis. And what we can do actually in the cath lab is using these tools that are able to integrate these images. They can understand the position of the probe, and when you move around with your C-arm in different projections, it allows you to perfectly combine together those images, and therefore you can get from echocardiography the best visualization of the structures of the heart that are normally not visible with fluoroscopy, and also you can get information on Doppler, colored Doppler, which is very useful also, for example, in this case, to localize the PVL.
Yeah, probably it was particularly in this case, probably color Doppler fusion was helpful in confirm the site of yeah. Oh, thank you very much.
It was very, very useful because it was also useful to better understand the position of the leak.
So
Linda?
Roberto, you go ahead.
Okay, so I just had two brief questions. The first one is, meaning, as you well said, first, nice case. You know, an alternative way of doing this, which we frequently do when we get into these type of problems, is to do a transapical approach, because that also leads you to cross the wire relatively easy. So, you know, how do you choose between each of them? Is it according to the experience of the operator? And then the other thing is, you know, putting a wire through a mechanical prosthesis is obviously at times complicated, right? So I wanted, and you say, well, we took good care, and I mean, I understand, but it could be complicated to do. So what type of wire did you use, you know, to do that? Was it a sapphire? Well, I don't know what type of wire you use, because that could be potentially complicated. And the third question would be, now that with fusion imaging and we people who do echo have gotten better at directing our colleagues in the cath lab where to do the transeptal closure, is there any particular anatomy of the atrial septal that allows you to better reach, you know, the posterior PVL than any other? Is that something that you consider when you do this?
Yeah, thank you very much for these questions. These are all very interesting questions. So first of all, let's start with a transapical approach. Actually, I think that the transapical approach for paravalvular leak closure is a really valuable approach in some cases like this one, which we really have to increase our support. We don't really have other options, and it's classically considered a good approach. But it is important to realize that it's a totally different procedure. It requires a surgical access to the LV apex, so it may be considered more invasive by some operators and for some patients, and that's the reason why we decided actually not to adopt it in this case. But it is something to consider for sure. Then regarding the question on the guide wire, it is very complicated to actually direct your guide wire to target a specific location in a mechanical prosthesis, which is something that is actively moving. We did so using the hydrophilic guide wires and guide wire, and I think we also were quite lucky to actually stick the central opening of the valve. What you can do in these cases could be to use a catheter to try to direct your guide wire, to better direct your guide wire. But in this case, we didn't have the chance to advance it through the PVL, and so we have tented multiple times and from different fluoroscopic angles. And your last question was about
atrial septal puncture.
Oh yes, yes, exactly. So I think the posterior location is one of the trickiest locations for PVL closure from a transeptal approach. I think it really depends also on the angle that you enter the right atrium, the angle between the inferior vena cava at the right atrium. It really can allow you to have a very high and posterior approach. But in those cases in which you don't have the chance to get very high and posterior puncture, an alternative could be to perform a low end anterior punction, which is something that might be considered like a counterintuitive. But if you adopt a steerable catheter, an additional catheter inside, like a child in mother system, you can maybe try to get this additional curve that you need to orient to the PVL. The first catheter needs really to go parallel to the mitral valve, and this can be useful, especially when you have to reach leaks that are quite far away in the big atrium.
Thank you very much.
All right, excellent. Dr. Gillam, do you have a last point before we move on to the next case?
Very briefly, certainly a technical tour de force, and I'm sort of glad you admitted there was a little bit of luck, because I'm thinking to myself, oh, even with the best planning, getting across that central orifice must have been, I would suspect there were high fives when you realized you were across. The question is, if the defect had been medial right along the interventricular septal, would you have rethought transapical versus trying to do, the approach that you took even with the rail?
Yeah, probably yes, because it is also a matter of the trajectory of guide wire. I think that if you have a trajectory that is quite parallel to the central opening of the valve, it is easier to get through this opening, and it is also more easy to reduce the interference. But if you have a lateral or a very medial position, this could be something very, very tricky. And also in the medial, in the case of a medial position, you also have a very narrow angle from the mitral valve to the aorta. So I think in that case we would have used a transapical approach.
Great case.
All right, thank you all. Great discussion as well. Otavio, I'll turn it over to you.
Thank you, Ahmad, for the introduction. So it's my pleasure to invite our third speaker of the webinar, Dr. Alex Pui-Wai Lee, who is the director of the Echo Lab of the Prince of Wales Hospital at the Chinese University of Hong Kong. Dr. Lee will present a fantastic case entitled, just one second, entitled Imaging from Transcatheter Tricuspid Annuloplasty using the K-clip device.
Thank you, Dr. Vario, for the kind introduction. It is truly my pleasure to share in this fantastic webinar on the case that illustrate imaging for a novel device that is used in transcatheter tricuspid annuloplasty, and a device called the K-clip device. These are my disclosures. So we have this referral of a patient's 86-year-old lady with chronic atrial fibrillation. She presented to us with refractory right heart failure despite optimal use of diuretics and other guideline-directed medical therapy. She has torrential functional TR, as you can see on this transradial echo, and because of her comorbidities and age, it was decided in the heart team that she was too high risk for a tricuspid valve surgery. And we initially planned to offer a transcatheter treatment for her tricuspid regurgitation, and the device available here in Hong Kong is transcatheter atrial repair with the a TriClip device. But when we study the anatomy of this tricuspid valve on TE, we found that there are several features of the tricuspid valve that may render this patient's not favorable for a TEER therapy. This includes that this patient have a 4-leaflet tricuspid morphology and also a very wide coaptation gap between the leaflets, and also the regurgitation orifice, instead of a focal circular orifice confined to the anteroseptal coaptation, it is a static shaped TR orifice that's basically involved all the leaflet coaptations. So we thought that this patient is not a suitable case for TEER. And in Hong Kong, we have access to a device called the K-Clip device, which is a transcatheter device that utilizes a clip-like strategy that we can see is a transvenous transjugular approach, that the clip-like device is steered towards the posterior tricuspid annulus and is then anchored to the tricuspid annulus through a corkscrew-like device. And this corkscrew, when it's withdrawn, it can withdraw the tissues of the annulus into this clip, which is then closed, achieving piclation of the tricuspid annulus and therefore achieving annuloplasty and TR reduction. So to plan for this procedure, we need to do a CT. So this procedure rely a lot of on the multimodality imaging. CT was used to assess the tricuspid annulus geometry, and also most importantly, the distance between the tricuspid annulus with the right coronary artery, because implantation of a clip-based device there has a risk of causing occlusion or kinking of the coronary artery. So we need to make sure there is an adequate distance between these two structures. And the procedure starts with a transvenous transjugular access, where the sheath is inserted through the jugular vein into the right atrium, and is all monitored by 3D echo and 2D echo in the bicaval view. And using fluoroscopy and also 3D echocardiography, we monitor the steering, which is a step 2 of this procedure, of the clip towards the target site of annuloplasty. In this case, is the posterior tricuspid annulus. And then we monitor the anchoring of this screw-like device component into the posterior annulus using this real-time multiplane reconstruction imaging technique. And then we do a tuck test to make sure that the annulus tissue is anchored. And then we started to orientate the clip arm in the clamping procedure step of this procedure. We make sure that the clip arm is oriented tangentially or parallel to the annulus circumference using 3-dimensional echo. And then using 3D echo with multiplane reconstruction as well as fluoroscopy, we monitor this withdrawal of this anchored, which pulled the annulus tissue into this clip arm, which will then close slowly to achieve annular piclation. So this is the result. The tissue is plicated or folded into the clip arm, achieving reduction of the annulus circumference. And before we release the device, we will do a coronary angiogram to make sure the coronary artery is patent. And then this is the result. After the release of the device, you can see that the device is stably anchored onto the posterior annulus. And if you compare the tricuspid valve structures and also the function before and after this K-clip implantation, you can see first, like the surgical K procedure, the annular reduction in the posterior component of the annulus can achieve this bicuspidization, or in this case, because it starts with a 4-leaflet valve, it's tricuspidization of the valve leaflets, and also reduction of the septolateral annulus and the circumference of the tricuspid annulus, and also a immediate TR reduction from torrential to mild to moderate. And 3 months later, this is the follow-up transthoracic echo showing there is sustained or even more progressive TR reduction. So TR is even further reduced into mild range, achieving a sustained TR reduction. In this case, the patient symptomatically also has shown improvement. So I think I will stop here in this case. I think illustrate the feasibility of using a clip-based device that can achieve tricuspid annuloplasty relatively easily with few steps, and also the importance of multimodality imaging in achieving procedural success in this kind of procedure. Thank you very much for your attention.
Thank you, Dr. Lee, for the outstanding presentation. Really nice images and a very illustrative presentation. And I would like to open this presentation to discussion, inviting the the moderators to comment and to post questions.
I wanted to ask you, first of all, great, very interesting new device. The first question I would like to ask you is, we hear a lot lately about all the different ways to classify tricuspid regurgitation. This patient that you mentioned had a huge right atrium, and the patient had atrial fibrillation. Was this, and you called it functional TR, is this atrial functional TR, or is this ventricular TR, and does that make any sort of difference? The second question that I have is, we also do some clipping of the tricuspid valve, obviously not with your device, but with just the more traditional way. And many of the tricuspid valve, when we do them, have these folds and so on. So my question is, at least in the first observation to me, is when you put the clip and you close, you somehow transform this tri-leaflet tricuspid valve into a bi-leaflet valve. It looked, at least it gives you that sort of feeling. And that brings to me the question, how do you, I understand the interaction with the right coronary artery, but how do you decide exactly where you're going to put that clip vis-a-vis the anatomy of the tricuspid valve?
Thank you, Dr. Lang. These are really important and great questions. So the first question is about the type of TR. We classify this case as a functional TR, and you mentioned about atrial and ventricular functional TR, and in this case, we believe it's probably a atrial functional because the RV-SP, the PA pressure was not particularly high. In this case, there was no left heart disease or pulmonary disease that can cause the pulmonary hypertension. And there is in contrast, there's a significant annular dilatation, right atrial dilatation with relatively normal RV size and systolic function. So we tend to classify this into the atrial functional TR according to the current scheme of classifying that. So how does it make a difference in terms of treatment decision? I believe that patients with ventricular function TR or with a severe pulmonary hypertension, they tend to not respond too well with whatever form of treatment you try to correct the TR, because the pulmonary hypertension is still there. If there's no way to correct that, the TR reductions tends to be not so impressive, and they tend to recur. And on the other hand, if you replace the tricuspid valve surgically or through transcatheter approach with the pre-existing severe pulmonary hypertension, the RV, we have seen cases that the RV failure can occur, and actually they do more harm in those patients. Therefore, these are the factors that we consider when in terms of the treatment in these two kinds of TR. And your second observation, I think it's excellent. Just like the surgical procedure, what we call the K procedure, it is actually a suture-based annuloplasty of the posterior annulus. And therefore, the target site of that procedure is to the posterior annulus, because it was believed traditionally that the tricuspid annulus dilate predominantly in the posterior, in the free wall, also anterior, but posterior, and also the anterior, which is the free wall part of the annulus instead of the septal. So that makes the rationale for the surgical K procedure, and also this K-clip therapy, which is trying to make the K procedure to target at the posterior annulus. But you're right, the exact location of the ideal site of implantation is actually still something that we are trying to learn more about.
Thank you very much.
This is Nozomi. Hello, Alex.
Hi, Nozomi.
Congratulations. Good to see you. So I wanted to ask you about the position as well. Roberto mentioned, but so currently, this is new for me. So currently, you do not change the position of the procedure in individuals. So
I cannot change. So before we release the device, actually the screw can be unscrewed and we can change the position. So if the reduction of the TR is not as it's not optimal after the first attempt, that we can actually reposition the device. Of course, we don't want to do it too much, because there's always a risk of coronary injury for every attempt.
So I have another question from the inside of an imager for the procedure. So it is often difficult to get the leaflet images, tricuspid images, in especially the on-face view by 3D TEE. So this is not the leaflet clipping. So that does this require only the position of a commissure on the annulus, and you don't have to get in clear leaflet images?
Yeah, that's a great question. Actually, one of the maybe a good advantage of this procedure for the imager is that it's less demanding in terms of the imaging. We don't need to see very clearly the tricuspid valve leaflet. Unlike the edge-to-edge repair, we really have to see that very clearly in order to achieve leaflet grasping and those things. We don't need to see the annulus clearly. And it's easier for TE to see the annulus, especially the posterior annulus, which is usually not, blocked. The ultrasound is usually not blocked by, things like the aortic valve or the mechanical valve on the left side. So the posterior annulus can be imaged in the transesophageal, mid-esophageal view, the RV inflow outflow view. You see the posterior annulus very clearly, and also the transgastric view. You can see the posterior or the inferior annulus very close to the your imaging probe when you're in the transgastric position, and also 3D reconstruction. So in the imaging point of view, it is easier probably than the edge-to-edge repair.
Fair enough. Thank you.
And I don't know, we're close to the end. Do I have time for one quick question, or?
Yeah, go ahead, Linda, please.
From an imaging perspective, it looked like you wired the right coronary artery. Is that right? It looked like, just to keep track of where it was during the procedure. But more to the device. I mean, we're not familiar with the device, and I've got to say, as you pointed out, it looks so easy as compared to the imaging that, say, goes with a tricuspid cardioband. So just when would you choose to use this device? You explained why it wasn't a good choice for TriClip, but in terms of a more circumferential annular remodeling approach, when might you try this?
Okay, so it's a great question. It depends on the availability, of course, of device in our locality. We have the HH repair device, and also, but for the annuloplasty device, we don't have access to device like what you mentioned, cardio band, and therefore, even we want to use cardio band, we don't have that access. But in this case, I think we have the option of choosing between an annuloplasty device and a replacement device. We do have replacement device here, but we have chosen the annuloplasty device. One of the reasons is that this patient has a history of bleeding when she was on anticoagulation. So for a replacement device, they would need at least a short period of anticoagulation, if it's not long term. So that's a decision point that we made, that we use the annuloplasty device. And I think one of the advantage of this device is that the steps are really relatively simple compared to maybe some other device available. It does not need to cross the tricuspid valve entirely during the procedure, and it does not need to penetrate the leaflets, and it is just a one-step procedure, and it's just anchor at the point rather than suturing multiple patches along the circumference, and so that the procedural time, for example, this case is only 40 minutes. So I think that's one of the major advantage driving the use of this device, at least in our center.
Certainly appealing. And if you can comment very quickly, in some of our tricuspid procedures, we use intracardiac ultrasound. Sometimes TE is not so easy to do for tricuspid procedures. So intracardiac ultrasound and transthoracic imaging, is that feasible with this procedure?
Yes, it's feasible, but according to our experience of like 50 cases in different sites, we don't need to use eyes in all of these cases, because the transesophageal imaging is usually adequate for the annulus.
Got it. A very interesting device and great presentation.
Thank you.
Okay, Alex, thank you very much for our presentation. And before I move to the closing message, I just received a question from one of our colleagues that are connected here that is pretty connected to what you were mentioning, and he is asking if you think that the current procedure may become an alternative, a competitor for the current devices that are being used. What's your opinion about that?
Thank you for the great question. I think he was referring to other transcatheter rather than surgical annuloplasty device. So will it be a big competitor? I think so, because I think the main reason is the simplicity. It's really make a difference comparing a 2-hour device, for example, with other annuloplasty device with a 2-hour procedure rather than a 30 minutes procedure. So I think, of course, we need to have more experience, and we have to have data and evidence with more patients and a longer follow-up period to really answer that questions. But I think the simplicity of the procedure is appealing for this device compared to other annuloplasty device.
Okay, thank you, Alex, for the great case and the great presentation. I understand everyone's enthusiasm over the current topic, but we have, unfortunately, to follow our schedule, and this webinar is actually reaching its end. I would like to first thank you everyone for sparing time in order to attend our first and hopefully of many Circ CVI case webinars to come. Your participation and collaboration were very valuable to us. Today, we had actually a unique opportunity to discuss in detail 3 outstanding cases with a panel of outstanding experts, and I have to thank you all of them to also being here, highlighting the importance of dedicated multimodality imaging in guiding complex structural heart intervention. I hope everyone enjoyed today's discussion and had a chance to learn something new from the real cases that we have presented here. Finally, I would like to thank you, the circulation staff, in the name of our managing editor, Carrie Muse, who made this webinar possible. Carrie, without your efforts, this webinar wouldn't be possible. With that in mind, I would like to pass the word again to Renee for her closing message. Thank you.
Thanks, Otavio. And then I'd like to mirror Otavio's comments. Thanks to all of the panelists. The discussions were top-notch expert discussions, and I think the cases were really high-quality cases, very difficult cases, but I think lots of learning points. And with that, I'd like to thank you guys for visiting us, for attending the webinar, and stay tuned for next webinar in a few months. Thank you.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
Thank you. Bye-bye.